So same format, a series of presentations, and no, do have a seat, otherwise it'll be too long for you. And as I asked before, if you can be, as you're listening, generating ideas, thoughts, comments, questions that you want to ask, and then Ian and I will pass them to the panel when we're done. So, welcome, Tom. You're in your home country. You're ready to go. Tell us what it's like. We're ready.
Beer and chocolate, Charles. Beer and chocolate. And football. Okay. No, I'm a basketball fan. That's another thing. Okay. My name is Tom Rentergham. I'm head of a department called Data and Policy Information in the Federal Public Service Health. Refer to this morning as Tom Says No. That's my middle name somewhere. Can I get my presentation, or is this? I have to click. Oh, okay, sorry. Next. Okay. Oh, perfect.
Yeah. Do you need any more?
It's okay. Thank you very much, Charles. I was looking at Terrence, and no joke here. The thing is, being at the end of the day, I heard a lot this morning. I heard a lot this afternoon already. And if I would ask to ChatGPT, okay, rephrase everything you heard with my slides, some things will be left over, some things will just disappear. But as I always say, to repeat certain things is the mother of all communications. So I'm sorry for that. You will have to bear with me if I repeat certain things that you already heard this morning. I was asked to give something about the implementation of SNOMED CT in Belgium. What's our vision? Where are we so far? What's the road ahead? To have some heads up there to the Belgian public, of course, but also to you as an international community. Now, if we look at vision and objectives, it's something that Nick already mentioned this morning. It's mentioned in different plans of the ministers, and I looked it up. 2022, 2023, with what has been explained by Nick, the quintuple A. This is for us a wardrobe where we can put things in, where we can go forward with everything that's our strategy now until we have a new minister, which is until the 9th of June, if I may put it that way, when we have elections or a new ministry or whatever. But we go forward with that for the moment. That aim is used in the e-health actions plans, is used in what Nick has explained this morning, in the beer, which is another thing than the liquid. But it's used in all the different acts and in all the different plans that we have. It supports different things, the adoption of SNOMED CT. In general, and that's why what my reputation, or to repeat, is coming. Things that you see here, data exchanges, semantic interoperability, it's a key thing. It's something that I hope I don't have to discuss this anymore in this room, and I hope that we are all aware of, okay, we have to use structured way, and I'm sorry, Philippe, I would love to have that discussion with you concerning free text or structured data, but this is one I'm convinced structured data is the way forward. It's used for decision support and evidence-based practice. Also, for me, that's a no-brainer. I mean, if you can combine the structured data in SNOMED CT with other data, you can get very far with insights, etc. Public health, something that Nick already mentioned this morning also. And here you have how it's happened in practice in hospitals in Belgium is that you have EHR systems where doctors are putting information in free text, something with drop-down menus, etc. for the moment. If you have SNOMED, they pick a SNOMED code or whatever. But at the end, this thing is coded into ICD and is used for financial methods. So what we get as a government side, we get, if I may call it, and I know I will have the whole public sector against me, but hey, optimized data from time to time, saying that, okay, if we get more finance than someone else, it's something that we have to do. It's like filling in their tax form. And that's something that we are aware of at the government, and we say, okay, using SNOMED CT is for the patient care. It's not for financial means for the moment, it's for patient care. It has to go from the front to the end, meaning that the doctor has to fill in the data and it has to stay there. It's used for secondary things, meaning that the same data is used for clinical research, is used for, and I know I have here the team for the medical audits here. Medical auditing can be used, or it can be used for many other things when it's coded once. And that's the thing that is really important. Specific for Belgium, we have what Nick explained, the beer. It makes beer meaningful if we implement it correctly. And tomorrow, one of our colleagues will explain to you all guys what beer is exactly about. So I don't get any further with that, because otherwise I tackle him, if I may put it the way in Charles is saying. And we want also SNOMED CT in different clinical systems. I'll explain later what I mean by that. Having said that, this is the way that we see things, that's the way that we want to go forward. And it's some things that I already heard here this morning or throughout the day. Automatic processing. If you code it once, you can get it through in an automatic way to certain things, to certain purpose, primary use, secondary use, and at the end, get the insights, get the analysis, get the statistics done, also on an automatic process. Now, implementation so far has said, or I have said that eHealth Action Plan, the principles is bringing together all healthcare initiatives on the way of digitization. Government, welcome to Belgium. It's starting to ring. Okay, government and public administrations, to get them all aligned, to get the noses in the same direction, to talk to each other and say, okay, this is what we want, this is how we see things, and this is how we get forward together under a shared governance. So each project that is within the eHealth Action Plan is assigned to an administration. It can be the Federal Public Service, it can be the eHealth platform, it can be regions, or it can be the National Institute for Health and Disability Insurance. Here you can see the different eHealth actions plans. So it's something that we have developed since 2013, and we're still in discussions to have the new one, 2025, 2027. And I will give a little heads up on that by the end of my presentation. What you see with this figure is how we see the things within, or how have we done the things within the different eHealth action plans. Are we there yet? No. Starting with that, we have built a SNOMED implementation program, which I will oversee with you right now. So here you see the different things where we have certain prerequisites. That's the work we have done so far to get the basis, to get the fundamentals, because without fundamentals, you can do whatever you want, and I'm still convinced of that. You can do whatever you want, you won't get there. You will have troubles or whatever. What we see and what we're doing right now is a shift in the focus. We're going from prerequisites towards implementation. That's the focus that we want to achieve in the coming years. So bear this picture in mind when I'm going to the rest of my presentation, because this is very important. And now I mention it, okay, we are here in a shift. If we look at translations, products and services, etc., And in the products and services, there's translations. There you see, there's no laser on it, or is it? Yes, there is. Okay, perfect. It doesn't work. Oh, here it works. So sorry if you.
Screen is across here, so you can.
Okay. If you look at the circle, there you see that in 2018, we started, at least I started as head of this unit with SNOMED CT. And thanks to the Belgian relance budget, we had a huge increase in translations. You can see the difference between 2018 and 2024. And I think, and I'm looking at David, it's the last figures that we have right now. Okay, so there's the last figures. And I can say that the German translations will be added in 2024. And I'm speaking now, they are in the release at this time. So get my figures correct. As I said in 2018, when I had the Belgian Terminology Day, there will be a turning point. Now, this turning point is almost there, meaning that we're going for the implementation. For me, the prerequisites are almost there. So it's a very important message that I have to give in the coming months to the Belgian health sector, that we're getting to that turning point. In the Belgian extension for the moment, and we're hoping to also to go to a Belgian edition, but in the Belgian extension we have translated content, and this is also Belgium, with 5 language ref sets. 1 Dutch, 1 French, 1 German, and then 2 what is called content-based ref sets for the GPs. Subsets, sorry. You have the medical ref sets, GPs, hospitals, nursing ref sets, value set ref sets, etc. We're looking also at the national drugs extension, and what you see with the simple map ref sets, these are things that are, how you call it, italic. These are the things that we're looking at for the moment, and we're planning also to get those things done. On stakeholder management, we are working together with Agoria, which is an organization in Belgium who assembles most of the tech companies, including software vendors industry. We're looking at end-user engagement, consortium of general practitioners. We collaborate with different hospitals, early adopter hospitals, CMIOs also, and we are also collaborating with academic institutes to do knowledge sharing activities. That's one prerequisite. The other one is our platforms. We have a terminology portal which is used as a central gateway to access all relevant terminology information, to browse to the terminology content, to register terminology requests, and to access technical tools. It's one-way portal. It's the authority portal where you can find the necessary information about SNOMED CT. In the slides, there's the link towards the portal where you can find it. On the national terminology server, it's also something that will be launched in this year, where we will host all national validated terminology content as an authentic source. It's the source where everybody in Belgium will have to comply with and will have to download the content from and use it in the interaction and interoperability in Belgium. It's one uniform readable format, and we're looking also at monthly releases in order to get the things done that we need to do so far. If you're looking at the implementation or the focus and the shift that we are doing right now, so we're working with the consortium of general practitioners to get also their language, because that's what we've done. We used their language, we mapped it to SNOMED CT, and That's what we have for now, for the moment. As a Belgian GP ref set, that's something that it's already existing and has been done. And what we're looking now for the moment is to get it into the electronic health records of the GPs. And we're doing that by co-creation with the GPs, of course, Agoria, our NSC, and the SNOMED International Implementation Support Team, in which I thank here formally for their help. Just to give you an idea, we started the first kickoff on January 2022, and we aren't there yet. It's just to give you an idea how long it takes on a practical side to get things implemented. So somebody is saying to me that SNOMED is just like a clip of a finger, don't buy it. It takes time, it takes a lot of effort, but it's worth it. And I have a great team to follow this up, but it takes work, it takes time, and that's something we all have to be aware of. What we're trying to do now is to get, and that's also thanks to the collaboration of eHealth platform, where they have what you see here, the homologation criteria, where they're saying, okay, dear GP software vendors, these are the criteria that you have to apply, otherwise you cannot sell any software here anymore in Belgium. And that's what we're doing right now. We force them a little bit, in a gentle way, but they have to comply with those certain criteria. There will some workshops, or there will follow, still some workshops will follow, sorry, organized by the NRC to look also at fire and care sets project. The road ahead. Now, eHealth Action Plan 25-27 built further on the previous action plans. We want to have a more transferable approach. We're looking at the new governance. And of course, we're looking at what we call BEER. Here you see the difference. This is what, on the top you see all the different projects concerning an eHealth Action Plan 2022-2024. On the other hand, if you see on the lower end of the slide, you see the BEER 2025-2027. We're thinking about using the projects that we are doing right now, but also looking at use cases. Okay, and how the projects that we're doing now are combined with those use cases. What can be done for those use cases? And Nick mentioned it this morning, if I'm not mistaken, obesitas as integrated care. So obesitas can be an example that we are using for the next eHealth Action Plan to work together with the other federal administrations to get the job done, if I may put it that way. Now, to give you a heads up of what BEER is what we call an integrated cradle-to-grave health record for all citizens. It's not a central database. It is an environment where patient data can be found in combination with a number of tools to maximize the use of this data to facilitate the care process. I won't go further that. I think Frederick will talk about it tomorrow a little bit more in depth, but just to give you an idea that it will be based on structured standardized data, and it is supported by, for the moment, funded hospital programs. And those funded hospital programs, and I'm going to put it right away, are the Data Capabilities Program and the Data Innovation Program. Just to give you an idea, it costs a lot of money. If I have to pay it from my proper purse, I would be bankrupt. But those kind of things cost a lot of money. You see here the common layers in all the projects, and that's done on purpose, of course, but it's something that we do in order to get going, is that they have to use SNOMED and LOIC, they have to use FIRE, they have to use the care sets, which is a value-based set of variables that for certain purpose are defined. Those are the three things that has to be done in all the project that has to be, that the hospitals are doing. We're not looking at that and saying, okay, here you have the money, you do your project, and okay, let's show us the result and job done. No. What we're doing here is working together with them, and my team is also having workshops with the different projects in the different programs to get the lessons learned. What do the hospitals encounter as problem, and how can we solve that? How can we look at it? What is needed to solve certain problems, etc. And that's the thing that we're doing right now in order to learn from that, in order to make some smart decisions, if I may put it that way. And one of those decisions that is in development or work in progress or whatever you may put it is one of these. We're thinking about developing roadmaps such as legislation. Okay, looking at legislation, if we want SNOMED used in Belgium, we're somewhere people who can always find a back door at certain things. So we will look at it, okay, where does the legislation has to change in order to get SNOMED into those kind of legislations. As I am also responsible of one of the largest registrations held in Belgium, which is a minimal hospital data, I'm looking at it to get it SNOMED based. And what should be done to get hospitals so far to get the information SNOMED based into our systems at the Federal Public Service. We're looking at mappings. And there I'm looking also at artificial intelligence. Now I don't know if Don is still in the room. He is. I have a partially answer for you. Artificial intelligence is always biased because it's coded by someone. That's the bias. But you can use it for your own purposes if you want to. And I'm looking here for those mappings. I'm looking here really at artificial intelligence. How can artificial intelligence help me, help my team, help us to get those mappings in order? And I think I'm quite convinced that there are some possibilities. So that's an example. We're also looking at collaborations. Okay, how do we, if we want to put SNOMED CT in hospital electronic health records, how can we work together? What should be done in order to get the things done that should be done on a government level? I don't know how much time I have, so I keep on going. 2 minutes. Okay. For wrap up, this is what I have already sent, but another way. So the roadmaps are for 2025 onwards. And at the right time, we will communicate about them to the public sector, to the hospital sector, I'm sorry. But perhaps some challenges. Challenges that I'm encountering in the different talks that I have. For me, implementing SNOMED CT is not a technical problem, it's a change problem. People have to change their mind. People have to change the way they're doing things. And that's the most difficult part. Change in a clinical environment, for me, is the most difficult part to achieve. Of course, it's technical implementation. And we're looking at maturity level 3. But there's also change management by the healthcare professional. Code once, use many, COM principle. Okay. How will we get someone who is happy with copy-pasting everything in his discharge report every time he wants to send it towards someone else? How do we get them to change? I don't have the answer. And I think if someone has it in this room, please let me know, but I don't have it for the moment. We should ask ourselves, okay, do we have to change incentives on that level? Do we have to reinforce that? They're already getting it from time to time in Belgium, but do we reinforce certain things? Vendor engagement has said already before this morning, It's something that we have to look at. How do we get there? I'm convinced that legislation will help the vendors to apply. Implementation of ICD-11, that's something that hasn't been said this morning. Nobody wants to touch it, I think. But the implementation of ICD-11, okay. I think that we have to do it through the implementation of SNOMED CT. Get SNOMED CT into the systems and then map it, for example, to ICD-11, or whatever the outcome between the talks about WHO and SNOMED is coming. So I'm excited for the coming years, but that's something is really a challenge. A challenge also, for the moment, is beer itself. How do we design or define a future-proof e-health architecture? I don't know if we already have the answer. I haven't seen it yet. Perhaps I'm wrong, but I don't think it exists. We have limited resources, so we have to be aware of that. And thanks to Constantine, thank you for that. I don't have to sum up all the different acts, so thank you for that. But alignment with the European health data space, other European and international guidelines will also be a challenge. It's very easy to set in words and on presentations, but on the working field, it is something that we're saying, okay, how will we do that? It takes time, it takes money, and it takes energy. Having said that, I'm not done yet. 2 seconds, Charles. This is for later. And this is something that I leave you to look up. So Terence, keep on your statistics on the international browser up. But I would thank you for your attention and I'm happy to answer any question.
Tom, we'll leave the questions till the end.
Okay.
But thank you for a really inspiring talk and really nice. Thank you very much. You've done Belgium proud. So our next two, I think we now have a pair of speakers. I'm not sure how you're going to do your double act, but presumably sharing the microphone. So welcome to both of you, and who are going to take us through the Swedish equivalent, I think. Yes. Fantastic.
You can hear. Right. First of all, thank you very much for, yes, I've got it, for us being able to come here and to give you an overview of what's going on in Sweden. Mattias and I, we will run through this presentation. Before we begin, I would just like to say that we will not be focusing on what are the projects that we are engaged in and what are the derivatives they are working on and maintaining in Sweden. Instead, what we will be presenting in this talk is to give you an overview of what's going on in Sweden. And we will touch on a little bit about the history of it, of how SNOMED come into the nation. A little bit about the complexities that we face, the realities and the challenges that is, I can say, learning lessons to learn, and also hindrances that we have to overcome. And lastly, we will also speak a little bit about a new beginnings, our change of plan, change of mindset, as Tom just mentioned. So, Mattias.
I have my cheat sheet. It's a very difficult word to say in Swedish, or as a Swedish person. I want to start a little bit with Sweden, the context, how Sweden is as a country. Geologically, or geographically, I mean, about 75% of the country is covered by forest, if you didn't know. We have about 11 million people, and the population density can range from, on average it is 22 people per square kilometer, but it can be as low as 1 person per square kilometer in some areas. We have an aging population. Last year, I think we had 1.47 births per woman. And yeah, as you can see on the for me, at the right hand on the screen, we have the structure of the government structure of Sweden. So the government are the ones that make the laws. They also give funding to various projects and agencies. We have a lot of agencies, and we work according to the instructions and funding given to us by the government. We have regions. They are larger geographical areas, and they are responsible for things that demand more resources, such as healthcare is a big part, but also public transport. We have several municipalities that take care of the more local needs, such as schools, social services, elderly care, but also some healthcare. Our healthcare system is divided in 3 levels: primary, secondary, tertiary. I'm sure you know them. And this affects the way we work, as the regions and the municipalities have quite a bit of self-governance. In the way of SNOMED CT, we as a government agency, we continue to provide SNOMED CT, and we have done for a long time, but it is somehow up to the regions and the municipalities when, how, and even if they want to implement it. And I'm sure Keng Ling will talk a little bit more about that. And I think we will switch.
Right. Yes, when it comes to implementing SNOMED, we adopt the top-down approach. Just briefly, how Sweden get into the picture was that in the year 2007, the Swedish Ministry of Health, it made the decision for Sweden to be one of the 9 charter members of an organization called International Health Terminology Standards Development Organization, the IHTSDO. I mean, it's a long word, but I'm glad they changed it to SNOMED International. What is it? That's really great. So then, when the decision was made, the government of Sweden appointed and commissioned the National Board of Health and Welfare, and that's where Mattais and I are working at. And we are a government agency as the National Release Center for SNOMED. Now, the reason for this decision is that the National Board of Health and Welfare was earlier instructed by the government to create and to maintain a national basis for common understanding and use of concepts, terms, and classifications. We were also instructed to create and to provide descriptions on appropriate information structure models based on national standards, legislations, and mandates to be used in aspects within healthcare and social welfare. So SNOMED fit in very well with the instructions given by the government to us. Now, a little bit about the NRC. Now, the NRC, that is us, we are actually 7 people. And among us, 5 of us are working with SNOMED maintenance. We have recently recruited a medical profession, and she will act as our medical advisor. And among us, we also have a strategist. So we are a part of a division of e-health and informatics, and we are operating under the Department of Healthcare Development, which was recently established. And the purpose of establishing this department is to provide guidance to the development of Swedish healthcare at the national level. Now, briefly, I mean, the NRC, I'm sure you know about it. Our main job is to produce, to maintain, and to distribute the Swedish edition to our local users. And we are also very happy to say that we utilize the services from the SNOMED International Managed Service team for our biannually release of the SNOMED edition. Without it, I don't think we could have managed. So very good. We got very good, excellent help from them. So apart from SNOMED maintenance, because we belong to a government agency, we are also expected to be involved in projects, other projects that is commissioned by the government. And so our focus can be divided between looking into other matters that can later lead to implementation, perhaps, or may lead to a reformation in the legal jurisdiction that is affecting healthcare and social welfare. But at the same time, we are also working with SNOMED. And when we work with SNOMED, we are very, very much focused in user support. So when it comes to user support, what we mean is that apart from the technical maintenance, we also interact with the users. Mattais will talk about it a little bit more, but we recommend them very highly to join the SNOMED International e-learning courses to upgrade their knowledge, because we realize that the more people know about SNOMED, the easier it is to implement SNOMED. And we also organize workshops, and we also have plans to invite the SNOMED International support team to help us with workshops to users, local users. So, Mattais.
Yes, so how is SNOMED implemented today in Sweden? It's probably to a varying degree in some areas, and probably not to a very high level. If we were to look at the maturity implementation framework, maybe the average would be about level 1. Some have plans to use SNOMED, others are using maps. We have several collaborators. We collaborate with hospitals and caregivers who are planning or are implementing SNOMED. We are working together with regions through various groups such as the National Collaboration Group, I think if I translate it, and the National Work Group, NAG. One member is here representing them today. We have bi-weekly meetings with them. And we also have several collaborations with the professional groups in Sweden, such as the International Council of Nurses, Dietitians and Nutrition, as well as microbiology. We also use our own knowledge base as an agency and those resources we have. And not to forget other agencies such as the eHealth Agency. In order to engage interest among others, we are holding open forum meetings once a month. They are completely user-driven. People can mail in questions beforehand and we will discuss them, or people can enter the meetings and bring their questions there and it will be discussed. We also attend conferences and hold workshops, as Keng Ling said.
Yes. These activities and spreading of knowledge of SNOMED and how SNOMED can be used, and also we encourage them to interact with SNOMED International. It is for us to help to increase the maturity level of implementation in Sweden. Now, what I'm going to describe here is a little bit about what we find within Sweden is a very complex environment. There are many factors that really affect SNOMED's usage. One of the first things we can look at is the legal systems, the mandates. Now, it is very crucial, I think, to consider this when taking into account, for example, the procurement of electronic healthcare records. And if the people who are involved in procurement do not understand, they may understand the laws around it, the mandates around it, but they do not understand SNOMED and how it should be used, it could be a problem. So it's very complex in the sense that we would like the legal system to understand, we will have to get the hospital to understand, we have to get the system developers to come in for us to understand how we're going to build the future healthcare system. So this can be, it takes time to change any legal legislation, and therefore it is not a hindrance, but it would require time for us to get there where we wanted to do. And I think this has been mentioned by several other speakers as well. Another factor that can hinder or slow down is we have to identify the users. There are many users. We are not only catering to one particular group. You have the vendors, you have the system developers, the medical professions, and researchers. And I think that SNOMED has a very large repertoire of 360,000 or more than that concepts, but it's not meant to use. So we have to train people to think, not only in knowledge, but also have to think and to upgrade their expertise in how to select which concepts are appropriate, how to curate, and how to develop and to maintain derivatives of SNOMED CT that are fit for use. And all this takes time and requirement from everybody. This is not a hindrance, but it will slow down the process. So as I said, that we have had other projects, and it is not within the scope of this presentation to talk about them, and there has been progress in the work that we've done in Sweden. Now, the other things that can affect implementation is the policies, if you can see here in this part under the national column. Now, there are regional as well as local level, large scale, small scale policies, the interactions between the different communities in healthcare, all these can affect implementation of SNOMED. Due to the complexities faced in a very high, diversified, as Mattais mentioned, that we are very heterogeneous. All the regions are, in a way, they are self-governing and they make the decisions. It is very important, therefore, that we working at the NRC are working in close collaboration, as Mattais members mentioned, okay, the national partners that we have from the National Collaborative Group and all the specialties associations that are present in Sweden. So and another problem that I have to mention here was that when we made the decision to adopt SNOMED CT to Sweden in 2007, that decision was made by the Ministry of Health without actually involving the decision makers from the regions. And this is a lesson learned, because when you do that, it is the regions who actually are the providers of healthcare. And they are the ones that you should have taken with us on the wagon when we go into discussion if to decide to be members of SNOMED International. But nonetheless, we are now working very hard to synchronize the intentions of the government and the efforts from the regions to achieve a more modern healthcare system. And therefore, we have this collaboration, with our active collaboration that Mattais just described. So that is what's happening locally in Sweden right now. And in the international arena, yes, everybody talked about the EHDS. Yes, Sweden was also a part of that work, and much of the work has been driven by our colleague here, Daniel Carlson, who represents the Swedish e-health agency. But we were also involved in this, and we found that it's a very good learning experience, because what we work with has application into EHDS. And we also have to talk about standards. Now, although Sweden is a nation of standards, we are very good in applying and using standards, but application and standards can be very complex, as we know. It's very easy to say, let's implement FHIR, let's implement OpenER, or let's do this and let's do that. But there are very many other issues behind it. There are very many local legacy issues in all the systems. Sweden, again, having so many different healthcare systems, and each one operating in their own way. How do we implement them? How do we unify them? How to get them to think and work together? So that is an issue and a challenge that we face. And also there are different code systems, some of them are international and some are local code systems that's being used in our healthcare system today. And how do we unify all this? How do we communicate with one another? So all these are challenges. And we also have another additional challenge is translation. We are translating the SNOMED CT edition from English to Swedish. And again, here I would like to point out that there is a lesson learned. When Sweden decided to join SNOMED International in 2007, they also made the decision to translate the entire 360,000 concepts to Swedish. And this created an issue because at every release, we experienced there will be problems with duplication in the translation or mistranslation. So if anybody ever wanted to do large-scale translation in the future, I would really advise that you implement, together with that, a very robust quality assurance alongside your work in translation. Because it is very important that our users do not select and use concepts that mean something else. So when it comes to international member organizations, we are very fortunate, I think, to be member of the SNOMED International, because we are able to move directly into the benefits that SNOMED International has brought through their work and through their collaborations with other international organizations, as you say, ICN, AJCC, with LOIN, with HPO. So we actually can draw a lot of the benefits, but it will take time for us to adopt and also to adapt them to our own national use. So I could say, just in short, we at the NRC, we are very much focused more on our national side than on the international side. And I think that's what we meant. We are the National Release Center. So.
I'll see if the microphone is giving up. Hello? All right. Yes, so this is how we want to start working. I'm sure anyone who has worked with the implementation of quality improvements recognize the PDSA cycle. We want to start implementing a more systems thinking. We want to understand the environment that we are working in, and not just the SNOMED CT parts, but everything around it, all the code systems that are used. And we want to start trying to understand how our changes will affect the other parts as well. And with this in mind, the National Board of Health and Welfare established a new department that gathered all of the divisions or units that has a larger effect on the healthcare system as a whole, in order to have the more holistic view over the Swedish health system. We have also started, or actually done, created an intended, let me see what I wrote, defined intended use for our products. We have seen that while we have done good work, if I may say so myself, in our respective areas, such as ICD translations and SNOMED modeling and translation, we have maybe given a confusing message outwards. We have said, when people question us, can we use this code system for this? We have said, well, yeah, you could if you want. But now we are going to start saying, if you want to use the code system outside of the defined intended use, we will not support you. We will support you if you use the code system for how we intend you to use it. We intend for you to use it. And hopefully that will make it more clear to the vendors and the end users. We also want to work according to the PDSA cycle. We want to start planning and doing more pilots with hospitals or others who want to implement SNOMED CT. We want to study and see the changes, are they good, what are the effects, and act upon them. Either if the change is not working, what do we need to change? If it's working and it's working very well, we want to work on spreading it throughout the country and not just leave it after the pilot is finished. So we come back to this this picture. We want to work on setting maturity level goals, both nationally but locally as well. We want to continue building with our collaborative partners, the ones I mentioned before, but more importantly, we want to set sustainable governance structures. One of the problems we had before was we created a lot of ref sets because we thought that was very useful, and no one were using them, and we were stuck with the maintenance of them. So now we started deprecating, that's another difficult word, deprecating them, the ones that are not used. And if we are creating new ref sets, we want the ones who will use them to take ownership of them, to make sure they are maintained, and to replace concepts as they become inactivated or otherwise work with them. And as I said, we want to continue staying after the pilots are finished to make sure the implementation is continue to grow and to spread the implementations. We want to continue having good engagement and communication networks with all of our collaborators. So that is our goal, and yeah, if you have any questions, I think that's the last slide. Yes? Yes. Thank you.
Thank you so much for a very clear overall view of what's happening in Sweden, and really helpful to have your thinking. We'll take questions at the end. So, and now we have Austria. So it's a bit like the Eurovision Song Contest, isn't it? You're going to sing or you're going to speak?
I'm going to speak, but speaking of the European Song Contest, I have to mention that I'm Swiss. So we were that last year. Thank you. Oh, but I'll speak for Austria today. So thank you very much for inviting me to this conference. I'm happy to have the very last presentation for today about SNOMED CT implementation in Austria. A few words about Austria. It's slightly smaller than Belgium and Sweden, with 9 million population, like regarding the population, with 9 provinces, also less than in Sweden, and the capital Vienna. And that is how Austrians look like when they work for SNOMED, or if they are representatives in SNOMED international bodies. You may have met one of us already, Stefan Savuc, in the General Assembly. We all work in the ELGA, which is the Austrian Electronic Health Record. He's also the head of ELGA. Then Nina Schwetz, who is currently on leave, Stefan Reineser-Blatnik, and me. I used to work for the Swiss NRC, so maybe we met before, but then for private reasons I moved to Austria, and since September 2023 I'm also working for the Austrian NRC. So this is also one of the advantages of SNOMED International. When you move to another country, you easily find a new job. Just make sure that it's a member country of SNOMED International. So yeah, we are 4 on this slide, but actually we all have other tasks, most of all Stefan Savuc. So actually, when you look how many hours we have budgeted annually, it's less than 1 full-time equivalent for the SNOMED tasks. So we highly depend on collaboration or support from other organizations and people if we want to develop SNOMED further. And one of our main supporters are these standards bodies. like the Austrian standards, e-health standards bodies, they are organized in an interoperability forum, and they give out recommendations also on terminologies, and their SNOMED CT is stated actually very prominent and is said to be the terminology that will be used strategically in future wherever other terminologies are not already widely established in Austria, which are not many others. So everywhere where you want to introduce a new terminology, you should use SNOMED CT. The reason is also given, it's because SNOMED CT is an ideal bridging terminology. What the recommendations also say about the binding nature, that it can only make binding within certain applications, or at least that's the way how Austria proceeds. And so it can made for certain use cases, it can be made binding by the ministry, by decree. At the moment, there's actually only one such use case, but a bigger use case. It's the ELGA itself, the electronic health record, which is governed by 3 bodies: the government, the states, and the social insurance. So you have the main bodies in the healthcare system, or this reflects just the healthcare system in Austria. You have them already on the project. So the ELGA is, you can identify yourself with the e-card, with the e-card from the social insurance, and the access is done by the Austrian ID. These are just other electronic infrastructure which you find in Austria. I learned that this makes a big difference, for example, compared with Switzerland, where you don't have this kind of infrastructure given, like the mobile signature or the social security card. And these two are really 2 pillars to build the electronic health record. So the ELGA, just a quick look inside of how the portal looks for the citizens. You can access your reports. The reports are not scanned documents and not free text. We are also more on the structured side. So the ELGA is based on IHE infrastructure and on HL7 reports, CDA reports. So there are only a few well-defined reports which can be shared within ELGA. It's structured content, but the CDA interoperability level is not always the highest. So it also appears sometimes that you just have the header structured and then you have a PDF embedded. So it's not as structured as it looks like. But of course, where we have the highly structured defined reports, you also have SNOMED, init, LOINC, and some other terminologies. This is the ELGA in numbers. I won't go deeper into it. You just see that it has quite some citizens, since it is an opt-out system, and most of the public healthcare providers. And you have these 3 types of reports: e-reports, e-medication, e-vaccination. But what we want to know is, where is SNOMED CT inside? If you look at it, you find it within the e-reports. There are different types in it. It's not on all the reports, but for example, microorganisms, allergies, and on the vaccinations, which is very highly structured. A lot of SNOMED CT inside, which is also due to the later point in time when it was introduced. The e-medication, there you don't have any SNOMED, and we already had this talk before. It actually mirrors the situation on the European level, and it also mirrors the strategy recommendation where to use SNOMED, like whenever possible in the new projects. We have a pathology project planned as like one of the next e-reports, and there, since it is a new project, hopefully, and I think that we will use SNOMED in it. There's also a look if you want to browse in our terminology browser, where we have over 300 terminology value sets and code systems. You can find these value sets with SNOMED CT. If you know a little bit of German, you also see the kind of content which is to be found inside. So this is on strategical level, on the operational level. So how is our everyday work as a NRC? The ELGA is also the, as I said already, the representative for the NRC in Austria. We are members since end of 2018, and we have just the usual tasks and duties every NRC has. For example, we give out the affiliate licenses. So far, we have over 150 licenses given out, which doesn't tell us anything how SNOMED CT is really used. What we can see is most of the applications come from software healthcare application developers, which makes sense, but we don't know how many sub-licenses they give out, and we actually don't know our consumers so well, or we don't know of a very big use case where a hospital uses SNOMED on the large scale. But luckily, we have some regional and university hospitals who are interested in having snowstorm server implemented in their house, so which would lead to a larger implementation and maybe also to a use case we can show around without Austria. And therefore, we will have, together with the implementation team of SNOMED International, a workshop on implementing SNOMED. So this is one of our tasks, but since we use the MLDS, the giving out licenses is not is a few quick clicks. It's not too much. Authoring, we haven't done much on this side yet. Maybe because SNOMED International is already so, SNOMED CT is already full of the content we need. But yeah, let's say we just have two own concepts up to now. We have a biannually release per year, and we give training courses, workshops. This year it will be 6 of them. It's more than the previous years because also the interest in SNOMED begins to raise, maybe also because of the other workshops. But of course we take this with pleasure, and we have the opportunity to give several online workshops a year. And this year, first time also an implementing workshop. Then we have change requests. There are 50 so far. So these are all small numbers, but our main task, our main concern, our main work burden actually are the translations. It was also mentioned before by the other speakers. So we want to have SNOMED CT in German provided to our users. It's also what the users ask. This is one of the first questions: is it available in German? And if you say no or not fully, they say, oh, then we cannot use it, which is not only true, but it's just what makes them hesitate to adopt SNOMED CT, or one of the hesitation points. So up to now, we have 40,000 concepts translated, which is about 12%. But when you look at our statistics, we had our first release in August 2022, starting with, I think, 340 descriptions. Now we have 55,000. It went up very steep. What happened? It's similar to the Belgian curve, but we didn't get more budget. We got some help from other organizations. So as a first point, we get translation donations. So there are organizations who want to have SNOMED, and we tell them we don't have the resources to give you the translations you need, but they can translate it themselves according to our translation guidelines. We will have a quality check, and so it goes very fast when we take over the translation compared if we had to do it ourselves. So we have really donations from translating from zero, but we also have donations where domain experts will check existing translations, as it was with the ICNP or Orphanet mapped terms. And so it goes, a big thanks goes out to all these domain experts who help to get SNOMED CT translated. And another big point, where I want to to have a deeper look into is the tri-national, it's now tri-national Germany, Austria and Switzerland, German translation group, where we join our forces together to have faster and better translation in German of SNOMED CT. So talking about this translation group, the GTG, one of the advantages is also that since we are a group, somebody has already made a presentation about the GTG, which you also share, so we really share everything. I took some of the content over from my colleagues. It was mostly Stefan Sabuc and Stefan Schulz who gave this presentation about the German translation group. So there are several countries which use German, or where German is at least a co-official language, which made us think that we could work together when translating SNOMED. And it happened in the summer of 2020, when this translation group was constituted. Professor Sylvia Thun, I think, was also one of the foundation members. Luxembourg used to be one of the partners. At the moment, they are not in the group anymore, but always welcome. Other countries are also welcome to join. So we made this group to translate SNOMED CT into German, and one of the first decisions was to make it use case based, because we don't have the power even together in a group to translate everything. And then to begin, you have to set the rules for the translation. I think this is a requirement by SNOMED International, but it's also just necessary if you want to translate SNOMED CT to have to get the rules right. So how to have your own editorial guidelines for your language. We took the French guideline as a blueprint, which was very helpful. And like 1 year later, we could release our first version of the translation guideline, which is always worked on it and elaborated further. So what are the decisions we had to take? One of the longer discussions was if we want to translate the fully specified name. Is it rather part of the concept, or is it something you really want to have in your own language? We decided not to translate it. Then we also had discussions about, which is a German specific, but I think also in Swedish, if you rather want to have word compounds or the word expressions with separated words. And then we also had a long discussions about the case sensitivity. We changed this rule 3 times until we realized that maybe the confusion lies further within SNOMED, or it's just not that clear. And these cases, there we are very happy to bring it into the translation user group, where we realized that other countries who translate SNOMED International have the same problem, or that we realized maybe one concept is very not as international as we thought, but rather US specific. So we just changed the rule that every word has the case sensitivity CS. This is our current rule on it. The workflow, as you see, everything that happens within the yellow box is done within the German translation group, so actually most of all. The NRCs, each country has its own extension, its own edition, and each country has its own use cases and brings the first translation to the group. But everything else is discussed and shared and decided in the German translation group. And we also use the same tooling, which also causes, or let's say it's not trivial, because Switzerland and we use the managed services, the authoring tool, and Germany uses the term space from TermMed. So we have different toolings, but we want to work together. And then we decided to have term space as the common tool to work on the translations, and everybody works on his own tooling concerning the authoring. From our experience is not so easy to bring the translation from one tool to the other. We are still struggling a little bit, and we are still working on the ideal process so that it works out fine for everyone. And I also want to thank SNOMED International for the support, for trying out different ways how to manage best. And there also, although we had some, we faced some problems, it showed that everybody on the group was ready to change its process to maybe have some common discussions. So we are not, nobody's dogmatic on his own tooling, and that makes the collaboration very agreeable. And this is also what I see for the outlook. It's just that we want to proceed as we did, to collaborate with the German translation group, but also with other domain experts to get some donations. In Austria, what is in discussion is a national compulsory coding for diagnosis. It's not yet written in stone or in the law, but it's probable that there will be some kind of compulsory coding, and even if it's ICD 10 or 11, or if it's named a certain terminology, I think this will help the SNOMED case as well, as like maybe the primary language or the mapping language. And another group who is helpful to our work is a group of family practitioners who made a lot of translations, who are very active, whom you get emails the weekend because I think they got up Sunday morning and say, okay, let's do something for SNOMED. But it's the best case also when they present SNOMED in a conference, you can really see the use case, and when the practitioners tell you that it's useful, I think this is one of the best ways, better than if the NRC worker who works for the SNOMED tells you the same. And what I'm also looking forward to a lot is the business meeting in April 2026. We will have most probably the chance to host the SNOMED International Business Meeting, and I will really like to welcome you all in Vienna by that time. And I also hope that I can present again the numbers of the Austrian translations, and that we will have about the same numbers as my colleagues on the stage. Thank you very much.
Well, what a great set of presentations that's been this afternoon. Thank you so much, Annatina. So over to you again for questions, comments, thoughts. Stunned into silence. Well, that's fair enough. It's been a long day, and I'd like just to sort of wrap up for 5 minutes. Is that a finger? That is a finger.
So I have a question for Tom. So you said that you were going to make mandatory the use of your terminology server services. And my question is, if you are going to do this bound to a specific care pathway, or is it mandatory in general? Every HR system needs to have that capability regardless of what it is using it for. So why make it mandatory?
I said that the use of SNOMED CT I will make mandatory. There's a law in Belgium that stipulates that for in the registrations that you have to use ICD. That's a law that I want to change. It's for me the logical way, and I will not have said that I will make the use of the server mandatory, but it's logical that this is the authentic source. So in the way that we see the things is that the authentic source is the server, of course, and if you want to get semantic interoperability on a certain level, there can only be one source. Otherwise, you will have difficulties in other concepts, in other meanings, etc. So that's something that you have to be aware. And we will make, for example, in the homologation criteria, they will have to point to the terminology server, saying that, okay, this is criteria that software vendors have to apply. They have to get their information from there. So it will not be written in stone, but it will be used by the criteria.
Did you get a reply?
Tom, you mentioned that you were doing these data innovation program pilots and that you were gathering lessons learned. Would you be willing to share those with the community?
Well, the thing is that if you have seen the dates, Shelley, it's the innovation project is 2025. So I'm happy to share it, but not now. 2024, those projects are still running. So we're still doing workshops, we're still encountering problems, but I'm happy to get back to you on a later date for that. In Vienna, perhaps, something like that.
Shelley, I'm going to give a sort of partial answer too, because I think there's a challenge for Ian and me to try and translate some of what we've heard today into some lessons learned. I mean, for example, we now know that there's a bunch of GPs in Austria who really, really want to do stuff, even on a Sunday morning. I mean, hey, I've never heard that, have you?
No, never.
And so we need to try and gather all of what we've heard today and presumably tomorrow in a set of lessons learned for our organization to spread the love. I'm just going to talk about 5 things that is there another question? Sir, speak.
My name is Friso. I'm a nurse in the Netherlands. I got a question, a bit the same question, but the guy from the software vendor was asking about the primary use of data. As a nurse, how it's been arranged in your country? As a nurse, I'm having an assessment. Am I going to do this assessment with the terms of SNOMED CT? Or am I going to do the reporting and the conclusion of the nursing diagnosis and then map it in the background of the HR? How it is organized in your country?
I'm looking at you.
Okay, it was
Go on.
your country, you mean all of our countries. In Austria, in the ELGA, we have a nurses report, which is not where you have defined, you could code diagnosis with a coding system, but it's not stated very clearly, and therefore we are now, we were approached also by different nursing associations who use different code systems, and I saw this discussion also reflected on the SNOMED international level. Do you want to use ICNP, NANDA, SNOMED? There are also POP and LEP used in Austria. So we are in discussion with them, but most probably SNOMED, or this is also what the associations see, SNOMED will be used as the bridging terminology. And if they use in their system ICMP or another classification system, they can do it through mapping. So, but it's in the plan, but a very pressing problem. I think every week we have some, we are approached by a nurse with this question.
Belgium wants to have time out.
Yes, when it comes to nursing, codes. We have, actually one of my colleagues, she's not here, and she's the one responsible for taking the nursing codes when SNOMED International and ICN went into an agreement. We have been able to take the codes, the nursing codes, and translated it to Swedish. Not only in the language, but also we add on to those concepts what we call the context. So in doing that, we work very closely with the Swedish Nursing Association, and we started the work. We've gone through, I think, a few thousands of these concepts, and we will continue to do that. When it comes to direct implementation, we have not actually done that yet, but there are discussions about it as to when and how. So it is actually a great help that when SNOMED International went into agreement, collaborating with an international organization, then we can just hang on to that and help. So it's a very good way of collaborating. Thank you.
I'm not going to talk about at national level in the UK, but from my own organization's perspective, I think we're not that far from actually what we've just heard from Sweden. But I would say there are sort of two areas where people often with a nursing background have grabbed the opportunities of SNOMED. So one is advanced clinical practitioners. They're not all nurses, but they often are. And they really like the use of SNOMED to describe what they're doing in extension or on top of maybe what the younger doctors are doing and so on. So they think they add real value by adding the sort of advanced clinical practitioner view to the more, perhaps the older-fashioned recording of diagnosis and so on that doctors make. A similar type of approach is happening in our emergency departments. Our emergency departments, I think, like everywhere in the world, but perhaps slightly more serious in the UK because of the long-term underinvestment in the NHS, our EDs have become a mayhem. There are so many patients that almost anybody can come and give an opinion just to help. But of course, we have advanced care practitioners there, we have nurses doing triage, we have doctors, all sorts. And in order to try and manage that at a national level, a group of doctors have developed something called the Emergency Care Data Set, which is a constrained set of SNOMED with a lot of nursing terms and maybe sort of less medicalized terms for describing the early part of a patient's presentation in the ED. Because of course, that is a complex process. Somebody comes in and somebody looks at the patient and says, "So what are you complaining of?" And the patient says, "Pain in the chest." And so that's recorded, but that's not a diagnosis. I mean, that's absolutely just a symptom, isn't it? And the flow of data through an ED that then says pulmonary embolus, myocardial infarction, Bornholm's disease, all of the things that it might explain. I think that's part of a long and complex process, but which does involve other professions giving a view about a patient's presentation, which adds value to the data set massively, in my view. I don't know if that helps to answer a bit. Any other secret questions? Okay, well, so I'm just going to wrap up with, I think, 5 takeaways from the day. And one of them is that we have heard a lot about the sort of two ends of how to make SNOMED work. So I think we've heard a lot from very senior administrators of health systems saying, it's in the law, obey the law, do the law. And I think that is really important, personally. I think it makes a huge difference. It sets a framework for action and a framework for organizations to deliver on strategy. So it is really important, but it does not engage doctors, nurses, and everybody else. So there you do have to work from the bottom up. And we've had some fantastic examples of bottom-up working today. I have to say I'm slightly ashamed of myself, but I had no idea that Europe did so much SNOMED. I mean, it's amazing. And I suppose I'm going to give you a challenge as a group, because it's one that I'm, again, forking over in my own organization, which is, this is the question. For what, 50, maybe 60 years, women of childbearing age have been prescribed a drug called valproate, which is really good for suppressing convulsions and epilepsy, but also produces congenital defects, sometimes in their children. Very diffuse kind of defects. But the challenge I would put to you is, can you, using your data sets in your EHR systems, whether in primary care or secondary care, identify the group of women who, one, can get pregnant, two, have some sort of convulsive disorder or other disorder, and are being prescribed valproate, and crucially, have they been assessed by a pair of doctors and maybe somebody else to say, do you really understand the risks that there are for you as an individual patient in taking that drug and still being at risk of getting pregnant? So it may not be a European issue, but it is an issue in the UK and has been for years. So there's now government legislation recommendation that we have to identify every single woman, and now actually every single man, because nobody knows whether the male involved in that conception might also be, if you like, the source of a congenital defect. Can you do that using your data? I don't know whether you can or not, and you can tell me over a drink, but I think it's a really great question and a really good use of SNOMED, because you ain't going to do that with ICD-10, let me tell you. Okay, my next point is, I think we've heard a huge amount about the benefits of team working. Team working within an organization, team working at the whole country level, and team working at the European level. And all I can say to that is, let's have more of that, let's do more of that, let's make the teams really, really highly functional. There's something I think I've learned perhaps more than ever, which is actually modern data formats are driving the change anyway. So HL7, FHIR, the resources that you can bind to FHIR and so on are making people use SNOMED, and that is transformational and a fantastic thing forward. I've learned or heard a lot, I think I already knew, but perhaps not that everybody's doing it, but the use of terminology servers fits with that agenda extremely well too. It is much easier to get to SNOMED, to go to a terminology server and use that, than trying to download RF2 files yourself into some PC and trying to make it work. I'm not, as you have already all guessed, an informatician of any sort, but I have never succeeded in doing any of that fancy stuff. But I think I can find something in a terminology server. And the last bit, you won't be surprised to hear, because I've already championed it once today, but is the benefit of doing this for patients. That's so central to the work you're all doing. And it's really about making sure that there are solutions of utility for that individual patient. So again, returning to the English course, I would say, and here I speak at a bit personally, but the ability to log on to my portable health record and using messaging, ask my GP to prescribe the medications that I'm on, which I then just pick up at the local pharmacy, is one of the transformational events, I think, for ordinary patients. Quite a lot of that, in spite of what was said earlier, is actually driven by SNOMED. because the GPs do have SNOMED in their systems. The hospitals don't for medicines. But it's that kind of stuff. And then I suppose to answer Don's final question, is as patients really get used to having a portable electronic health record, the creation of a cradle to end of life health record makes such a difference to one as an individual patient and the people who are charged to looking after that patient, who are usually the relatives. We all depend enormously on our friends, our wives, our husbands, our children to look after us as we get older. And them being able to access information about those episodes of care using structured data and not having to filter endless PDFs or that lovely scratchy thing that we saw from Austria, which I guess you moved on quickly from that, but it wasn't quite clear what that was going to tell us. But that ability to pull data out and use it as a carer of some other person is the thing that we're all after, in my view. So I think we've had a fantastic day. I really look forward to tomorrow, and I hope you'll all return and learn with me. Thank you very much.